Hello, Abhay. Can you hear us?
Hello, good morning.
Good morning.
Yes, we can, Dr. Seth. Good morning, everybody.
Good morning.
It's a pleasure and honor to be part of India Live,
It's great to have you.
especially from Triple M. So, good morning, all panelists, and Dr. Jagdish will inform us about the case.
Sure.
Good morning, respected chairpersons, panelists, and dear friends. We have a 59-year-old male, a diabetic hypertensive, who had been operated by us, bypass surgery in 1999, 2 grafts, Lima to LAD and a left radial to the OM. And he presented 3 years later with exertional angina in 2002 and had a stent to the circumflex where we found the left radial to be occluded, and the Lima was patent at that point of time. And he presented 1 month ago with unstable angina, and he has a good LV function.
Is it going like that?
And we can see the radial, the RC is totally occluded, and this was before the stent to the circumflex. And the next angiogram will show a patent Lima and a stent. And this presentation, the next slide please, we'll see an instant restenosis of the circumflex. The RCA remains occluded. The plan is to do the instant restenosis of circumflex stent, and over to Dr. Rajpal for the proceedings.
So, what we have here is we have taken a 6 French sheath in the right radial artery, and AL2, an Amplats 2. Is it AL1 or 2?
AL1.
This is an AL1. Patient is not a very tall person. And we see that we have chosen an Fielder XTA and a microcatheter, a Corsair 135 centimeters. We had the option of choosing a Fielder XTR and a Fielder XTA. We opted for the Fielder XTA because it's more about crossability rather than trackability here. And the Fielder XTA has a tip load of 1 gram compared to a Fielder XTR of 0.6. And this is a very good wire. It's tapered tip, composite core, polymer jacketed. So we opted for this wire. So we see crossability as an issue, but trackability is, there's nothing greatly tortuous here. So this is the wire and we are working on it right now.
Okay.
If we can show you a slide, that slide, can show a slide. Probably it'll come up. Till then, let me see if I can. Yeah, now if you can see this slide, this is a very simple slide which shows us the puncture needle that we use. The Thermo kit comes with a puncture needle which is 54 millimeters in length. We use a Gelco which is around 32 millimeters and which is not a part of the radio focused Thermo kit. Next slide please. If you see the difference is so much in length, and therefore we prefer this needle which is much shorter and easier to control. So now we are working on we are trying to cross this lesion. Next. So any thoughts on the wire that one should use or anything that you have in mind? We didn't do a dual injection because honestly they were in the diagnostic angiogram that we saw, we didn't see much collaterals.
So here's my question to you. We can't judge it from here where we're sitting,
Yes, please.
but did you see any faint antegrade track at all, or was it all bridging collaterals?
I believe there's a faint antegrade track.
Right. That's partly the impression we were getting, but we couldn't be sure. See,
Yeah.
and
So, but we will know now.
soon you'll know. The biggest issue about these old, and this is an old bare metal stent, instant restenosis, because the stent was put in, I think was said 2002, is the fact that these are fairly hard.
Yes,
These could be
2002.
calcific, and they are sometimes not easy to get through
Yes.
and need firmer wires. So let's see. It's a good start, because if you got an antegrade channel, we'll know, but we'll also know whether we need to go to harder wires.
Yeah. So right now I'm taking my time, I'm not pushing this. And trying to slowly work my way through. Yes, please.
This 1 gram tip is like probably across at 100, which is, I think, 1.5 grams.
Sorry?
So what do you think your progress is?
Well, I think we'll need some more time to make sure, but we seem to have got into one island. But I just want to make sure I've not got into one tiny branch. I think I've reached one island wherein the vessel seems to be a little bigger. So at this point, after which the vessel is totally occluded. So if I get my microcatheter there, having crossed this, I may change for a stiffer wire, but I'm not sure.
And we can't see from here, but are you within the boundaries of your stent in both views? See, the problem with these,
I'll give you a stent boost for us and me. You have
Yeah.
a stent boost?
because the problem with all these
So both of
micro
us can see, all of us can see.
collaterals is that you could actually
Sir,
go
stent
beyond the
boost?
boundaries of the stent as well,
Can you collimate?
if it's bridging.
Yeah, let me look at that. Are you ready? Stent boost? Stent boost? Oh, it's not auto stop, huh? Yeah, so I've taken a stent boost for you. I hope we'll be able to, we'll show you that blown up image. Stent boost, ready? Enachu? Tight. Let's go. Just go, please. Okay, thanks. Yeah, so if you see, we have actually crossed part of the stent,
Right.
and I think we are going in a little different direction, so I'm going to redirect my fielder XTA. this is a better wire compared to the R. You get more 1:1 torque.
Mhm.
And we have a better tip load. It's 1 gram compared to 0.6. So, this is what I've chosen, but I don't think this penetration power is enough now.
Yep, that's what happens with instant
But I've sort of
restenosis,
crossed-
chronic instant restenosis. They get very hard,
Konja center
sometimes
area of
even
interest.
calcified.
Center. Konja collimate pannunga. Just center the area of interest. Okay, fine. Thanks. Thank you. So I may also, if I'm not sure, switch to Miracle series. I don't want to take a Gaia here.
So would love to see where you are at the moment by
Injection.
drawing the microcatheter and injecting to see whether you're in the right path, direction, where do the collaterals come in.
Yeah.
You won't get anything
If I
down
remove
at the
the
moment.
microcatheter and inject, I lose. Yeah. So I lose my position. So I'm not sure. Is that the way to go?
You could still inject and see because you're going to see collaterals. Where were the collaterals to this vessel coming from?
Actually, there were not many collaterals. Whatever was there was faint antigrade flow.
So none of the vessels.
Run the first shot, please.
Yeah, let's see the first shot and see where the collaterals came from.
Bridging
Yeah,
collateral.
bridging collaterals.
See, you only see some faint antigrade flow,
Yeah, bridging collaterals. Well,
or maybe bridging collaterals.
More
Maybe,
of
yeah.
bridging collaterals.
so looking at the path you're taking seems to be in the same direction as at least this vessel.
Yeah.
And then you should sort of look at it in the other view as well, just to give you the comfort that you're actually in that path.
Another option, another thing that I might do is remove this remove the wire and make a tip injection. I think I'm hitting the hardest part of the. If in the freeze பண்ணுங்க the injection freeze பண்ணி வைங்க please. Just give a slave here. இல்ல அந்த first injection. Yeah, இத ரன் பண்ணுங்க please. இங்க ரன் பண்ண முடியல. அத ரன் பண்ணுங்க நான் frame select பண்றேன்.
See, that tip injection is something I don't like through the
Please.
end hole catheters, especially when we're wedged into tissue.
One back.
Because of the possibility of creating a dissection which propagates and then you lose your original path completely.
Yeah, we lose everything. Yeah, I know. But if I give an injection just now, I don't think we'll be seeing anything.
No, with the microcatheter there you won't see anything. But you're progressing somewhere.
Yeah.
So if the 1 gram wire is progressing somewhere, I mean, that's a comfort zone.
Yeah.
Yes.
It's not going to, it's a wire which has the least chances of perforation and has the greatest chances of finding its own path. At least these chances of going into false channels. But let's see. Oh, we can have comments from my colleagues. I'm just keeping a conversation on, by the way.
I think it's already made some progress, and that's a healthy sign.
But now, Abhay, most of us, at least in the hall, are thinking
Yes,
that
please.
they would love to see something at least of the distal vessel that you've gone so far. And I tell you, I would be quite comfortable by leaving the wire there, slowly withdrawing this microcatheter and giving an injection in 2 views and at least taking a deep breath in and saying, I'm on the right track. You've got fairly far.
கீழே வா தம்பு.
You got fairly far,
Yeah.
and I'm not sure whether you're in the right track. Because if you were here, you should be floating around now.
Okay,
Tip is not free yet.
Yeah,
yeah,
It's not moving free, yeah.
it's not moving freely, it should be. So nothing wrong in withdrawing this microcatheter by leaving the wire there.
yeah, okay, let me do that. See, I think I've gone into a small branch at some point. Let me see.
So let's have a look at an angiographic shot.
Yeah. I want to come down slowly.
Yeah.
Yes. But I don't lose anything and I get into trouble. Yes, please. Just see where. Yeah, please.
Ashok,
Yep,
I
Abhaichand bhai.
think, it's, you have to see the distal segment. And without that, you do not know where exactly you are
Yeah,
going.
yeah.
The way this wire is bending,
Ashwin bhai, you should be on the podium because
Okay.
this is a CTO.
okay, all right. I think the way the wire is bending, I strongly feel it's in the false passage.
Right.
That's right.
And I think the way to do is what exactly you said, that remove microcatheter and make an injection from the guide catheter. And
Correct.
that's quite safe. And
That's
it
quite
does not
safe.
create any harm.
Yeah.
And I think because we got to see where we are going.
Yeah.
And the choice is that in case if you are finding resistance, then I think the best thing would be to take ultimate, not miracle, but ultimate 3 because it has a lubricity.
Just.
And it's a good compromise. 3 gram tip load,
Yeah.
lubricity, and a little acute tip, about 45 to 60 degrees.
Right.
And that would be the way I would go.
So it appears that, yes, you were partially in the right direction, and then you've obviously taken a wrong path.
Sini.
And I agree with you, Ashwin bhai, that his proximal segment is okay.
There
He-
it is.
yeah.
Now you can see this, Ashok.
Yeah.
He's outside.
That's right. So therefore,
Yeah. Just coming back and redirecting with this wire.
you see,
Mother.
my feeling is that this redirection with
Sini,
this wire
can you store it?
is going to be very difficult because the tip conformability is lost. You really now have to actually have a tip which points in this direction in
You're
a
right.
half-
I think
in a
the
harder
tip-
wire.
The tip might have lost the shape.
Yeah, probably I'll take another wire. This time I'll probably take a little stiffer wire.
Yes. And with a curve which actually directs you in the right direction. That's the first step to that, I think.
Rajpal, whatever you like,
Yeah.
you can take, but I think I suggest that you take ultimate. If you have that on the shelf.
Yeah, please. Give some heparin, 3,000 heparin.
So-
I'm going to spend some.
So which wire are you here now, Rajpal?
It's the same wire.
It's the same wire.
Oh, I'm with the same wire.
Okay.
I'm with the same wire. And I've reached a second island, which you can see. I may change to a different wire now. Let me see how I feel. I thought you're going to be with Matthew now. Okay, come, show me that. Show me the.
Yeah, we somehow got back to
Dila,
you, though we were with Matthew very briefly.
Okay.
Yeah.
0.2.
So let's see his monitor. And how are you doing?
Is this making sense?
So, could you show us any of the last pictures that you have?
What wire is this, Rajpal?
It's a miracle 6 gram.
Okay. Miracle 6.
Okay, show the last one, please. Show the RO. Okay, now, yeah. Now, if you see, we are in one tiny branch, right at the bottom. Now, can you please show the last shot? Yeah, this is the RO caudal. Now, I'll tell you what happened so far. We have a suspicion that we did cause a small dissection. Yeah, we did cause. But then we have got back into it, into the true lumen, and if you look here, there's a small branch which takes off. At the bottom, after the curve, there's a small branch where our wire is now. If you look again, we need to come back. We need to come back and go into the main branch, which is curving to the right. I don't know if I'm clear on this.
So, Arun, what do you think?
Yeah,
Is
Dr.
it
Rajpal,
all
hey.
right? Does that make sense?
Dr. Rajpal, hey, Arun here. So, yeah, it does, and it looks like you have a second
Yeah.
occlusion and a stent right there, right? At least the way it's projecting here, it looks like there's
Yes.
So something
Yeah.
Something to consider is to pull your microcatheter back, just confirm that you're truly in the lumen and in the branch further down, and then you might want to, it's going to be hard for you to, with this tip to make that penetration. So once you confirm your intraluminal, bring your microcatheter close to the proximal cap of the second part of the occlusion, and then try. It's probably what I would do.
Like, you mean parallel wire or something?
Yeah, but you're not convinced that that I'm in the true lumen?
It's doubtful.
I would just take another shot just to confirm, because I didn't actually see the wire in the lumen. So it's
No,
possible, I just don't
think,
know.
You know, the terminal portion of the wire.
So you
Not
want to
because
come
this-
back? You want the microcatheter back?
Yeah, it shouldn't take you more than like 30 seconds to bring it back to where it was. I would just confirm that it's the distal
So
wire
we
is in the
have
true lumen.
bought. We
Yeah,
have
so
got-
let's
we have
watch
one
this
second.
and
PMU one
short, and then go to Matthew, and because we've run out of time, but we still
Yeah,
want to see
normal-
where you
normal.
are and where Matthew is.
second. Fluoro. Cine.
Yeah,
So
so,
it's away. It's
Yeah,
distinctly
you can
outside.
see contrast. You can see contrast.
Hey,
where your nose cone
So
is,
what I'm planning
the
to
nose
do
cone
now
of your
is-
catheter is where probably the true lumen actually goes backwards. So yeah, you just tell your plan, because then we're going to go to Matthew.
Yeah. So I'm going to take the microcatheter right down and then come back up a little and then change my direction or probably take another wire.
Okay, so we leave you with that, and we'd love
Yeah,
to
yeah.
see if at some
Yeah.
stage we'd see this final result. Abhay, can we go to Matthew now?